Now we go to steroid hormone biosynthesis, metabolism in action. So this is an overview of the processes that happens in adrenal steroidogenesis, how your steroid hormones are synthesized. So your steroid hormones are synthesized in your inner mitochondrial layer. So from the cytoplasm, remember that your precursor molecule is your cholesterol. It's the parent molecule of all steroid hormones. So your cholesterol enters your inner mitochondrion, and this is the first rate limiting step in adrenal steroidogenesis. The entry of your cholesterol into your inner mitochondrial layer. And this first rate limiting step is facilitated by your STAR, your steroidogenic acute regulatory protein. So that's the first rate limiting step in adrenal steroidogenesis. So if you have a defective STAR protein, let's say you have a genetic defect encoding this protein, then usually it's not compatible with life because you are unable to synthesize the different crucial steroid hormones needed to survive. So these babies usually don't survive for long and have multiple congenital defects at birth. So after your cholesterol enters your inner mitochondrial hormone, it can go this way or this way or this way. So depending on the layer of your adrenal cortex. So the presence of certain enzymes in the particular layer will dictate which hormone will be secreted. So for example, in the zona glomerulosa, the predominant enzymes here are these enzymes. So therefore, the end product will be your aldosterone. And so on and so forth in this layer. So let's go first to the inner zona reticularis. And the major hormones that are secreted here are your your DEAs, or your androgens, particularly your DEA and your androstenedione. So your cholesterol enters the cell, again, the inner mitochondrial layer, and this is converted, your cholesterol is converted to your pregnenolone, and this is stimulated by your CYP11A1 enzyme, or more popularly known as your cholesterol desmolase. So that's the second rate limiting step in adrenal steroidogenesis. The reaction facilitated by your cholesterol desmolase, and your cholesterol desmolase is the enzyme that catalyzes the conversion of your cholesterol to your pregnenolone. And then your pregnenolone is acted upon by this enzyme to become 17-hydroxypregnenolone, and then your 17-hydroxypregnenolone will be acted upon by this enzyme and converted into your DEA, and it is sulfated and becomes your DEAs. No? Your DEA, or your dihydroepiandrostenedione, is now acted upon by your hydroxysteroid dehydrogenase 382 to become your androstenedione. And your androstenedione is the major adrenal androgen precursor, and it's also considered an androgen. It's one of the most abundant androgens in the body. So your androstenedione, the major adrenal androgen precursor, can now be converted into your testosterone, and your testosterone is now acted upon by your 5-alpha reductase to become your more potent, more active 5-dihydrotestosterone. No? This happens in your gonads, or your testes. Of course, it's different if it's your androstenedione is in the ovaries. It will eventually be converted into your estradiol. So we'll discuss that when we go to your male and female reproductive endocrinology. So if you go to your zona glomerulosa, your pregnenolone will be converted to your progesterone, and your progesterone will be acted upon by this enzyme to become your DOC or your deoxycorticosterone, and then acted upon by this enzyme to become your corticosterone, and then eventually to your 18-hydroxycorticosterone, and then eventually to your aldosterone. So all of these hormones will have some degree also of mineralocorticoid activity, no? So, but the most potent one will be your aldosterone. Next, your progesterone can, if it goes into your, if it's produced in your zona fasciculata, will be acted upon by this hormone to become your 17-hydroxyprogesterone, to your 11-deoxycortisol, and then eventually to your cortisol, and then your cortisol is your major glucocorticoid hormone. So your cortisol is deactivated, no, by your hydroxysteroid dehydrogenase 11 beta 2 to your less active, to your inactive glucocorticoid, which is your cortisol. So, and then your cortisol can also be converted to your more active cortisol by your hydroxysteroid dehydrogenase 11 beta 1 enzyme. So I don't expect you to memorize the enzymes, no? Except of course the rate limiting enzymes, no? So, but otherwise, all the other enzymes that are stated here, you don't need to memorize. The precursor molecules, you don't need to memorize. I just wanted you to have an idea of how things work in your adrenal cortex, no? But the important ones that you have to remember are the rate limiting steps, because those are the ones that are usually acted upon by drugs, no? And how they are modulated in pathologic states by certain drugs. And also because those are the ones that are asked in your exams, particularly your board exam. Okay? So next we'll go to so we've gone through the anatomy, physiology, and then briefly your steroidogenesis. No? So we'll go to proceed to the third objective for this lecture series, which is for you guys to be able to identify patients with signs and symptoms of hypercortisolism and mineralocorticoid excess, particularly your Cushing syndrome. So the disorders of the adrenal cortex follows the general pattern in endocrine disorders. So you have hyperhormone secretion, your excess, your hormone deficiency, and your hormone resistance. So for each layer, you can have any of those. So you can have glucocorticoid excess, and the prototypical syndrome will be your Cushing syndrome, and there are also others, pseudo-Cushing syndromes. And then you have glucocorticoid resistance, glucocorticoid deficiency, primarily your primary hypoadrenalism, if the problem is with your adrenal glands, secondary hypoadrenalism or hypocortisolism. So they're interchangeable. That's your, usually that's pituitary, it's the problem. You can also have post-chronic corticosteroid replacement therapy. So those are your, that's also a form of secondary hypoadrenalism among patients who have been on long-term corticosteroid therapy, resulting in prolonged suppression of your hypothalamic pituitary adrenal axis. And of course, there's your congenital adrenal hyperplasia. And these are spectrum of diseases caused by deficiencies in the different enzymes in your steroidogenesis. So we will have a separate lecture on that as well, part of this lecture series. And of course, you have your mineralocorticoid excess, mineralocorticoid deficiencies, and your masses, of course, your tumors. That's your adrenal incidentalomas, adenomas, and carcinomas. So that's an overview of all the disorders of the adrenal cortex. Pretty much follows the pattern of endocrine disorders as well. But some of these rare conditions, so we will not be tackling those. You'll probably never really meet them in your lifetime, no? or you can probably refer to a specialist, subspecialist for further workup and management if it's a very rare condition already. But you guys must know the must knows, of course. No? And in this case, we'll be talking about your Cushing syndrome. So your Cushing syndrome is a constellation of syndrome caused by chronic exposure to excess glucocorticoids of any etiology. So it could be from endogenous uh, glucocorticoids, excess glucocorticoids, or it can also be either from the adrenals or the pituitary, or from an ectopic tumor, or you can have also exposure to exogenous, synthetic steroids, glucocorticoids. So those are your tablets, no? So they're all lumped together in Cushing syndrome. So you can divide Cushing syndrome into ACTH dependent and ACTH independent. So your ACTH dependent can be divided into your pituitary and your ectopic ACTH syndrome or your EAS. Then your ACTH independent will be mostly, the problem will be coming from your adrenal gland, usually from an adrenocortical adenoma. Adrenocortical adenoma if it's benign, adrenocortical carcinoma if it's malignant, and you can also have nodular adrenal hyperplasia. So there's no specific tumor within the adrenal gland causing the excess glucocorticoid synthesis and secretion. And of course, you can also have pseudo-Cushing syndrome. Those are alcohol, depression, and even obesity, which can mimic symptoms of Cushing syndrome as well. So remember that ADO, alcohol, depression, and obesity. Those are your pseudo-Cushing syndromes that can mimic Cushing syndrome. So we will tackle mini G. Mini G is Harvey Cushing's index patient. Remember Dr. Harvey Cushing? I talked to you about Dr. Harvey Cushing in one of our lecture series in pituitary. He's a very prominent neurosurgeon who had particular interest in the pituitary, and he was very meticulous about documenting his patient. And this was one of the most well documented Cushing patients, Cushing syndrome patient. So this is Mimi G. And she was a 23-year-old female who presented in the Hopkins Hospital with obesity, hirsutism, and amenorrhea. And Mini G, no, can what do you notice about her signs, no? So if you can see, the most prominent one will be your truncal obesity. Of course, it's black and white. It's hard to see, but you can. It's hard to see the colors, but you will see some striae here. Most likely, these are either reddish to violaceous striae, very typical of Cushing syndrome. You can also see a buffalo hump in her neck. There, buffalo hump. The acute hump at the back of your neck, no? And you can notice her legs are very thin. You can see some muscle wasting as well. And this mini G also had markedly elevated blood pressure. And when they worked up the patient, this patient actually had pituitary adenoma that is secreting excess ACTH. So this was a case of Cushing's disease. Okay, so as I was saying, Cushing's disease is an ACTH producing pituitary adenoma, and this is of course under ACTH dependent Cushing's, and majority of Cushing syndrome will be from ACTH dependent Cushing's, no, 90%, and majority of which will be from your pituitary, called Cushing's disease. No? So when I say Cushing's disease, it means the Cushing syndrome is coming from the pituitary. So to a lesser extent, you also have your ectopic ACTH syndrome or your EAS, and this is due to an ACTH secreting ectopic tumor outside other than your pituitary. It could be from a bronchial carcinoid or a pancreatic carcinoid, a small cell lung cancer, even a medullary thyroid carcinoma or a pheochromocytoma can be sources of your ectopic ACTH syndrome. But these are very, very, very rare conditions. No? So aside from that, you also have your ACTH independent Cushing syndrome. Not as common as your ACTH dependent Cushing's, and but the most common cause of ACTH independent Cushing syndrome will be your adrenocortical adenoma, and very rare will be your adrenocortical carcinoma. And even more rare or rarer is your macronodular adrenal hyperplasia. So all these rare conditions, they're just nice to know. No, they're just nice to know. You don't need to memorize them. The one that I wanted to highlight here is that ACTH dependent is more common than ACTH independent, but the most common ACTH dependent will be your Cushing's, and the most common ACTH independent will be your adrenocortical adenoma. And the most common tumor causing ectopic ACTH syndrome will be your bronchial carcinoma. So again, the most common tumor that causes ectopic ACTH syndrome is your bronchial carcinoma. Okay. So these are some pictures of patients that shows some features of Cushing syndrome. So what do you notice in patient A? No? So you will see, what will you see? You will see truncal obesity again. There's your buffalo hump. No? It doesn't show here the striae, but you can see that probably from the side, that's your moon fascies. So this is a patient with centripetal and also some form of generalized obesity with dorsal kyphosis here. Okay. And this is a 30-year-old female with Cushing's disease. How about in patient B? What do you notice? Very prominent. Very prominent will be the moon fascies, no? The moon fascies. There's also some degree of facial plethora or redness in the face. You will have supraclavicular fat pads here, no? And some hirsutism. You didn't notice that right away, but you can see that there are some, that the patient has a beard here, no? Females aren't supposed to have a beard there. And as I mentioned earlier, your supraclavicular fat pads. No? So there's abnormal fat deposition. This one, patient C, you see the side view of your moon fasciitis, no? Your facial rounding, your hirsutism here. There's also some degree of acne, no? If you look closely. Okay? And this is a 14-year-old, relatively very young, 14-year-old female also with Cushing's disease. How about this one? This one is a male patient. No? What do you notice? No? Aside from the moon fascies, the supraclavicular fat pad, there's also some degree of gynecomastia as well as your central obesity. So this is a 14-year-old boy with Cushing's disease also. Okay? Now what we go down the body, no? So this is patient E. What do you notice? You have your centripetal and also generalized obesity and your striae. And what you see here, there's a bruise, no? Signal, which is a sign of easy bruisability. This one is a male patient. You also have your violaceous striae, your bruise there, no? So this patient is a 41-year-old female with Cushing syndrome. They didn't say the book didn't specify whether this is adrenal or a pituitary Cushing syndrome. This one is a 40-year-old man, with very prominent abdominal striae. It has to be violaceous or reddish, no? If it's just your whitish striae, usually that's from typical stress usually from pregnancy or from weight loss, no? Um, but if it's whitish, it's not Cushing's. But if it's reddish to violaceous, it's usually Cushing syndrome, and it has to be 1 centimeter at least in uh, width, 1 centimeter. This one is the typical striae in a patient with congenital adrenal hyperplasia that was treated with excessive doses of dexamethasone. So, in patients with congenital adrenal hyperplasia, because they have a deficient enzyme, they can have cortisol deficiency. No, cortisol deficiency, or sometimes we give steroids in order to suppress the excessive ACTH. So I'll explain that to you when we go to your CH. But in essence, this patient received excessive doses of dexamethasone. So this is from an exogenous Cushing syndrome. So the striae can extend down here also, in your legs and in your buttocks as well. And last, you have your typical bruising and thin skin of a patient with Cushing syndrome without obvious injury. So this is your typical violaceous striae, easy bruising and poor wound healing. They have very thin skin, no? And then you will have hyperpigmentation of knuckles in a patient with ectopic ACTH, no? Because, ectopic ACTH. Very typical hyperpigmentation, and of course, this is your buffalo hump. Okay, so these are the clinical features of Cushing syndrome. As you can see, it has many, it affects the entire body, no? It can affect body fat, skin, bone, muscle, cardiovascular, your metabolism, your reproductive system, even your CNS and blood and immune system, no? Aside from everything that I mentioned, I'd like to highlight here also the effects of Cushing syndrome on your bone. It's either your osteopenia or your osteoporosis. Some patients will present with vertebral fractures, or if the Cushing syndrome happens in children, they can have decreased linear growth. In the muscle, you have your proximal myopathy, which is a very prominent feature of discriminatory feature of Cushing syndrome. There's prominent atrophy of your gluteal and upper leg muscles. And in your cardiovascular system, you can have hypertension, hypokalemia, edema. And because of the hypercoagulable states, they're also very prone to deep vein thrombosis and pulmonary embolism. Patients can, because of the excessive cortisol, can have glucose intolerance and even secondary diabetes. No? And this is because of the upregulation of gluconeogenesis, lipolysis, as well as protein catabolism. So you can have both secondary hypertension and secondary diabetes. You can also have decreased libido in women. No? They can have amenorrhea. This is because of cortisol-mediated inhibition of your gonadotropin release. In the CNS, some patients present with this. They only have, some patients would have mental status changes, and then upon workup, you will see features of Cushing syndrome. That can happen sometimes, no? They can have irritability, emotional lability, even depression, no? And in severe cases, paranoid psychosis. So sometimes they present also in the ER because of this paranoid psychosis, only to find out they actually have Cushing syndrome. And as I mentioned earlier, no, your hypercoagulable state. So you can have effects also in your blood and immune system. So how do we investigate patients with Cushing syndrome? So you have to ask two questions. First, you have to confirm, does this patient really have Cushing syndrome or not? Maybe this is just pseudo Cushing syndrome. If yes, we now proceed now to find the cause. No? So again, first question you ask, does this patient have Cushing's? Next is, what is the cause? It is essential to determine this in order to guide radiologic investigation. No? So in endocrinology, we always do biochemical testing first. No? Always do biochemical testing first before imaging. No? As I mentioned earlier, Cushing syndrome has many possible etiologies. It could be from the pituitary, it could be from an ectopic tumor anywhere in the body, it could be in the adrenal gland. You can't image everything. No, you can't image both the pituitary, the chest, the abdomen, the adrenals, just to look for a tumor that could potentially um, cause the Cushing syndrome. So it will be your biochemical testing that will guide you which part should you image. And also, remember, there's such a thing as an incidentaloma. I had a patient before who had a pituitary tumor and an adrenal tumor as well. So I didn't know which is which because when the patient came to me, the patient already had imaging studies. No? So keep that in mind that it doesn't mean there's a tumor, that it's the one causing the excessive hormone production because of having such a thing as incidentalomas. No? So how do we approach these patients? So if you have a patient that you suspect to have Cushing syndrome, so you have your prototypical constellation of signs and symptoms, no? At this point, you should already consider endocrinologist consultation at that time. But while waiting, no, you can actually start working up the patient, using screening tests for Cushing syndrome. So these are the different screening confirmatory screening test. Usually we do at least two, no, just to be sure, no. Either let's say we can do one urinary free cortisol excretion, and it has to be 3 times elevated, no, 3 times the upper limit of normal. Plus, we do a low dose dexamethasone suppression test. Sometimes we do the dexamethasone suppression twice, no, or we do a midnight plasma cortisol. So um, these are all, this algorithm is from your Harrison, and this you can choose from any of this, no? But of course, it will depend also on the patient, no? Because some patients, for example, you have a patient with a chronic kidney disease, then it's your 24-hour urinary free cortisol may be erroneous, no? So before screening, consider first if there are any possibility of exogenous glucocorticoid exposure. So that's the first thing you do, rule out exogenous Cushing syndrome. Usually we suspect this, no, in patients who have history of arthritis, no, because some patients, they self-medicate with steroids. No? Steroids are very magical in patients with arthritis because just one tablet and they the arthritis or the pain is gone. No, sometimes patients with eczema, patients with asthma, no, they would self-medicate with steroid tablets, particularly either your methylprednisolone, your prednisone, your dexamethasone. No? Sometimes their neighbor will tell them, "Why don't you try this tablet?" No? And it will magically help their problem, whether it's asthma, eczema, or arthritis, or whatever other condition. And then they pop it like pain meds, and then some patients, they become dependent on it, that when some patients report that when they take the steroid tablets, they feel stronger, no, they feel like it's vitamins, so that's why they get sort of a little bit dependent on it. I don't want to say addicted, but more of dependent on taking those steroid hormones. And before they know it, they already have Cushing syndrome because of the exogenous glucocorticoid chronic exposure. So if the patient does have exogenous glucocorticoid exposure that it's quite significant, then you can actually do away with doing this screening test. But if you suspect that it's something endogenous, then you proceed with screening. Now, if a patient turns out positive with the screening test, then you do confirmatory testing. So usually we do a low dose um, dexamethasone suppression, low dose dexamethasone suppression test over 2 days. Sometimes, if there is any discrepancies in any of the screening tests, and then now you since you already are able to answer the first question, does this patient have Cushing syndrome? You now try to find where it's coming from. So the first step is determine whether this is ACTH dependent or ACTH independent Cushing's. So how to tell? You do a plasma ACTH. So very, very crucial step. Sometimes if there's any doubt to the accuracy of the ACTH test, we do it twice just to make sure, because if there's any error here, it will really mislead you whether to go here or to go here. No? So for plasma ACTH, if it's normal, it's inappropriately normal. Supposedly, if you have elevated glucocorticoids, your ACTH should be suppressed. No? So that's your ACTH independent Cushing. But if your patient, despite having elevated glucocorticoids, and your ACTH is still normal, no, called inappropriately normal, or even high, more than 15 picograms per milliliter, then you can say this patient most likely has an ACTH dependent Cushing's. There. So if your patient has ACTH dependent Cushing's, no, it's either one of two, either pituitary or anectopic PCPH syndrome. So we usually do an MRI of a pituitary, a dedicated imaging just for the pituitary. No? So it's important to do a pituitary MRI and not just do a routine cranial MRI. In areas where there's availability of your CRH test, you can do that as well. But here in the Philippines, you don't have that, or it's not readily available. Or you can do a high dose dexamethasone suppression test. No, you give a high. It's similar to your 1 milligram dexamethasone suppression test, but you give a dexamethasone that is at a higher dose, and supposedly it should override the 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 pituitary adenoma that's causing the excess ACTH production. If it's not able to suppress, most likely it's pituitary. So if there is high dose, during the high dose dexamethasone suppression test, there's no suppression that happened, most likely it's Cushing's disease. So the treatment for that is transsphenoidal surgery. If there is an equivocal result, then you can do inferior petrosal sinus sampling. No? But of course, this is under the guidance already of your endocrinologist. If the pituitary MRI is negative and your high-dose dexamethasone test is negative as well, then you can now consider an ectopic ECTH production. So you now search for where the ectopic ECTH tumor is. Usually, since the most common is the lungs, you do imaging of the chest first with high-resolution CT scan to look for bronchial carcinoid. If it's not there, then you look for in the abdomen. You look for pancreatic carcinoid. If your patient turns out to have ACTH independent Cushing, so the source is your adrenal glands, you do a CT scan, no, and then if there's a mass, most likely it's that mass, no, and then you proceed to do the other workups for your adrenal tumor, because you also have to work up the patient for the other layers of the adrenal cortex, other layers of the adrenal gland. Importantly, you have to rule out pheochromocytoma as well. So if there's a no tumor, then you can consider this one, bilateral micronodular or macronodular adrenal hyperplasia. But of course, this is very rare. So what is the takeaway message for this? The important thing here really is this one. No? How to screen. At your level, I want you to be able to know how to screen the patients at least. No? And once you've confirmed, you can actually refer already to your endocrinologist. And also, I want to highlight also differentiating between ACTH dependent and ACTH independent Cushing's. No? The rest are just nice to know. No? This one and this one. Nice to know. You don't need to memorize all of those, but at least you have some form of understanding. Okay? So I'd like to go back to this. Now remember this, the physiologic cortisol circadian rhythm. This is the basis for the screening test. So remember, we do your midnight salivary cortisol. Our expectation is the levels will be very, very low because it's the nadir, at 12 midnight. But um, but if it's more than 5 nanomole, meaning it's elevated for at 12 midnight cortisol, it means that there's excessive production. So how do we do this? When the patient is about to sleep, we put a cotton buds inside the mouth and get the saliva at 12 midnight, because any stress, like if you do blood extraction, that can falsely elevate um, your cortisol. So that's why we do the salivary cortisol. The low dose dexamethasone test, no, we give a 1 milligram dexamethasone at 11 p.m. So the dexamethasone will suppress the peak of ACTH. Remember, the peak of ACTH is at 6 a.m. No? And therefore, if you suppress your ACTH, it will also suppress the peak of your plasma cortisol. And you should have a suppressed plasma cortisol at 8 a.m. If your plasma cortisol at 8 p.m. is not suppressed, meaning it's more than 50 nanomoles per liter, then it is abnormal because your dexamethasone is unable to suppress the peak. Therefore, there's something that's producing excess endogenous glucocorticoid hormones. Next, imaging. So once you confirm that this is an ACTH dependent Cushing syndrome or your Cushing's disease, you can now do an MRI. So this is an MRI of a patient with a pituitary microadenoma. You see the hypoechoic tumor there, no, very small. It's still confined within the pituitary, so it's less than 1 cm. So it's called a microadenoma. So usually Cushing's ACTH producing adenomas are usually very, very small. We don't expect a very, very big tumor in patients with Cushing's disease. No? So pituitary MRI is the imaging of choice. No? It can even be negative in up to 40%, no? Especially if the tumors are very, very, very tiny. No? Majority are microadenomas. If it's an ectopic ACTH syndrome, we do a high-resolution CT of the chest and abdomens, looking particularly at the lung, thymus, and pancreas, because those are the usual sources of your carcinoid tumors. If you can't locate it in your routine HRCT, we do a functional imaging, and that's your octreotide scintigraphy. You inject the patient with some radioisotopes, no? Radioactively labeled isotopes, and then it goes to where the excess ACTH secretion are, and then you image it, and usually it lights up, no, in your scintigraphy. How about this one? This one is Cushing syndrome from the adrenals. This is ACTH independent Cushing syndrome. So you will see in a normal adrenal CT, you have your small adrenal glands. Usually it's Y-shaped, L-shaped, no? Very small. So if you have a patient with bilateral adrenal hyperplasia due to excess ACTH stimulation in Cushing's disease, you can have enlarged adrenal glands, no? So this is a patient with ACTH dependent, no, Cushing syndrome. So you might be misled if you do an abdominal CT scan and you see abdominal adrenal gland enlargement, no? Adrenal gland enlargement from the excessive ACTH stimulation. You might think that this is an adrenal Cushing's and take out the adrenal glands, when in fact the source is actually your pituitary. So this is solitary adrenal adenoma on the right. The left adrenal gland is not very visible here. So this is your adrenal Cushing's. And you can have also massive macronodular hyperplasia. As you can see, there are multiple nodularities in your adrenal glands. No? So how do we treat? If it's Cushing's disease, we do, your best bet is your transsphenoidal surgery. Now, if there's recurrence, you can do radiotherapy. If in extreme cases, very extreme cases, intractable cases, no, you can do a bilateral adrenalectomy, but it's a very, very morbid procedure. If the patient has adrenal Cushing syndrome, of course, you do an adrenalectomy. If it's less than 4 cm, you can do a laparoscopic surgery. In ectopic ACTH syndrome, you can do, of course, once you locate the tumor, if it's in the lungs, you do surgery. If it cannot be located, then I can do medical therapy. You know, there are also some medicines that can suppress cortisol synthesis and secretion, or do a bilateral adrenalectomy. Medical therapy, they can rapidly control the cortisol excess during the period leading up to surgery. But the most common is your metirapone, followed by your ketoconazole, and you have also mitotane. Now, mitotane is a very, very strong adrenolipid agent that usually we use this for adrenal carcinoma. However, all these drugs are not available here in the Philippines, so usually we import them from either Singapore or even India. No? So that's the end of part 1. The next topic will be your mineralocorticoid excess. Okay, see ya.